today we'll have a talk by Dr. Ritika Malik, and she's now in working in Lucknow, and she's going to give us a keynote talk today. So we'll have her talk to start the session today morning. Welcome, Ritika.
Address from my last year's free paper award. So it was based on the paper which was on next generation cross-linking calculator for titration of energy in thin keratoconic corneas. So I have no conflicts of interest. So we do know that the management of keratoconus varies from the 450 microns or less. We can do an epi-on cross-linking. We can either do an intacs, or we can go with advanced disease of full thickness or lamellar penetrating keratoplasties. So, but what about those cases which have advanced keratoconus without any scarring? So in these cases, we can think about doing what the earlier problems were, that we were thinking about doing a hyposmolar riboflavin-induced cross-linking, transepithelial cross-linking, contact lens associated cross-linking, and customized pachymetry-associated guided cross-linking. But all these papers showed that there wasn't a very good survival with the graft, and these added advantages were not there, such as higher order aberration calculations or unpredictable outcomes were there. So what can we do for cross-linking the thinner corneas without any scarring? So Dr. Farhad Hafezi's team gave a sub 400 protocol. What should be done below 400 microns of thickness? So he gave a fluence customization where the customized energy is delivered by altering the irradiation time. So a lower UV dose can be administered from the beginning. So shortening the irradiation time has no effect, what we have seen, and also in Dr. Farhad Hafezi's and Dr. Ebad's Pearl's paper, that there was no effect on actually how the outcome was. So this paper also gave us stress relaxation curves for the different conditions and stated that the effect of cross-linking is more dependent on the duration of the UV radiation than to the overall applied UV fluence. So this led us to a research question: is there a simpler way to calculate energy, titration and time in thin corneas? So this is how we designed a calculator using the Lambert-Beer equation to present a simple on-time calculator. So how do we use that? So the change in thickness changes the fluence time. And how is the change of thickness calculated? We calculate it by subtracting the epithelial thickness with the overall thickness of the cornea. So this is also the chart which we use of 3 milliwatts and also the 9 milliwatts of corneal thickness power. So with this background, we decided to evaluate the performance of the NXT-UVA calculator, and after taking approval from ethics committee, 70 eyes of 70 patients with advanced keratoconus with documented progression, corneal thickness less than 400 microns, and with, very important, no scarring was included in the study. So each patient underwent a corneal topography to determine the documented progression. Then thickness was mapped with the epithelial mapping. Then specular microscopy was done, AIOS was done, and NXT-UVA algorithm was again placed in the pre-op period, and then the cross-linking was done. So this is a short video which we show. For example, we have a TCT thinnest cornea of 390 microns. The epithelium off was around 340 microns, which corresponded to whatever we added in the app, came to around 21 minutes at 3 milliwatts and 7.3 minutes at 9 milliwatts. So we used 0.1% riboflavin, and it was instilled by the accelerated protocol. So at 1, 3, and 6 months of follow-up, we assessed all the patients for the best corrected visual acuity, topography, specular microscopy, and AIOS. So coming to the results, there was no significant haze noted on pentacam densitometry, and clinically at the end of 6 months also, they were all safe. So 51% had no loss of lines, and 24% were gaining one line, and the loss of line was very minimal in just about like 0.2 and 1.4%. Specular microscopy showed no statistically significant change in the cell count before and after the procedure, so it showed that it was very safe even in the thinner corneas. They were stable in the keratometry values also at 6 months, and the Kmax value was also stable. The demarcation line was documented in 62% of our patients, and it was present in most of our patients, and it evolved over the 9 months what we did the longitudinal study for. So it was showing good clinical outcomes in even of a severe of the cases. And we also adjusted the biomechanical strength. So we did see a stress strain index, and 65% of our post-op patients had no biomechanical weakening. So a polarization sensitive OCT was also done for these patients, and it showed that the collagen orientation and density in the cornea patients were also improving. So we do know that our standard cross-linking is not giving us good results with our thinner corneas. Our study is based on a simple calculator which is freely downloadable, and it's easy to use. It's not requiring any other additional methods such as iontophoresis or a contact lens. The limitation of the study currently is that a long-term follow-up is required. We are currently up to the 1-year follow-up. We do require some more patients in the cohort. So this is the QR code also with the link, which gives you directly to the code and the NX2 UV calculator. Thank you.